Neoplasm or tumor signifies a new growth arising from a single transformed clone, leading to unregulated cell proliferation. Normally, cell growth is regulated by growth factors. Genetic mutations in a transformed cell lead to cytokine-independent cell proliferation, causing uncontrolled and uncoordinated cell overgrowth. Neoplasms are classified as either benign or malignant. Malignant neoplasms involve uncontrolled and uncoordinated proliferation, along with metastatic characteristics. Metastasis is the process where a primary tissue cell migrates to a secondary tissue via blood or lymphatic drain. Malignancy or cancer can be liquid, like blood cancer, or solid, like breast or prostate cancer. Blood cancers include myeloproliferative neoplasm, leukemia, plasma cell dyscrasia, and myelodysplastic syndromes. Leukemia is the malignancy of hematopoietic stem cells, with the transformed clone arising in lymphoid or myeloid stem cells. Leukemias are classified by cell maturity and cell lineage. Acute leukemia involves immature malignant cells, while chronic leukemia involves predominantly mature cells. Based on lineage, leukemias are divided into lymphoid and myeloid types, with myeloid encompassing granulocytic, monocytic, erythrocytic, and megakaryocytic leukemias. Lymphoid leukemias relate to the lymphocytic cell line. Based on cell type and maturity, leukemia is divided into 4 broad categories: acute lymphoblastic, acute myeloblastic, chronic lymphocytic, and chronic myeloid leukemia. Abnormal proliferation of lymphoid cells within lymph nodes is referred to as lymphoma. This video further explores the classification of leukemia. This is the WHO classification of leukemia. Several factors contribute to leukemogenesis, including genetic susceptibility, somatic mutation, viral infection, and immunologic dysfunction. Hereditary factors and abnormal genetic material are strongly associated with leukemogenesis. Congenital abnormalities with karyotypic abnormalities carry an increased risk of developing acute leukemia. These genetic events can activate proto-oncogenes or eliminate tumor suppressor gene function, such as in Down syndrome. Somatic mutations can be caused by radiation, certain chemicals, and drugs, leading to chromosome mutations. Ionizing radiation is known to induce leukemia. Chemotherapeutic drugs also increase the risk. Benzene is the only chemical, other than medications, specifically implicated in causing leukemia. Retroviruses such as human T-cell leukemia virus and human immunodeficiency virus can cause leukemia. Retroviruses contain a reverse transcriptase that allows them to produce a DNA copy of the viral RNA core, which can integrate into the host cell's nuclear DNA. An oncogene in the viral genome can activate a proto-oncogene in the host cell, leading to leukemia. An increased incidence of lymphocytic leukemia is seen in congenital and acquired immunologic disorders, like Wiskott-Aldrich syndrome. A breakdown in the self-surveillance system or deficient antibody production may lead to the emergence and survival of neoplastic cells. These are additional factors in the etiology of leukemia. Any cancer-initiating mutation in a stem cell, due to an etiological factor, creates a cancer-initiating cell. This cell, which can be a hematopoietic stem cell or a more differentiated progenitor cell, gives rise to a cancer stem cell. This sustains malignant growth, eventually leading to metastasis. Major clinical problems of leukemia include anemia, infection, and bleeding episodes. Other common complaints are bone pain from marrow expansion and weight loss. Hepatosplenomegaly and lymphadenopathy may also occur, being more common in chronic leukemias. Skin infiltration is frequently observed in acute myeloid leukemia, especially those with a monocytic component. Central nervous system involvement is common in childhood acute lymphoblastic leukemia. Chloromas, which are green tumor masses, are associated with AML and CML. Laboratory investigations for leukemia include a complete blood count with a peripheral smear, bone marrow examination, cytochemical stains, immunohistochemistry and flow cytometry, cytogenetic and FISH analysis, PCR, and biochemical and radiological investigations. A complete blood count and smear examination initially evaluate for cytosis or cytopenia. The peripheral blood film is examined for cell morphology and abnormal cells. Reticulocytes are also counted, and the smear guides further diagnosis. Bone marrow aspiration evaluates abnormal cells, hematopoiesis, and fungal cells with cytochemical stains applied. A biopsy is performed to assess cellularity, bone architecture, and fibrosis, with immunohistochemistry stains applied to the trephine slides. Cytochemistry involves in vitro staining to microscopically examine the chemical composition of cells. Cells are incubated with substrates that react with specific cellular constituents. The formation of a colored product confirms the presence of the constituent. Cytochemical stains, such as myeloperoxidase and Sudan black B, differentiate between myeloid and lymphoid blasts. Esterase is used to differentiate monoblasts and myeloblasts. Periodic acid shift stain is negative in myeloblasts. Tartrate-resistant acid phosphatase stains hairy cell leukemia. Immunohistochemistry is based on identifying specific membrane antigens, or surface markers, characteristic of a particular cell lineage. Monoclonal antibodies react with specific CD markers and are color-coded for diagnosis. Genetic analysis includes cytogenetics to determine the cell karyotype, which is crucial for defining some neoplasms. Molecular methods like PCR and fluorescent in situ hybridization are used to identify specific gene mutations, even if the karyotype appears normal.